Okay, it's 4 p.m. actually already 45 seconds after, so it's time to start. Good morning or good afternoon to everybody. This is welcome to the second session of the master classes on medical physics. Today's session will have 4 presentations made by Brígida Ferreira, Radhe Mohan, Cátia Pedro, and João Seco. So the first presenter is Professor Brígida Ferreira. She is an assistant professor at the Faculty of Sciences at the University of Lisbon. She has done her PhD in medical radiation physics at the Karolinska Institute in Sweden on biological optimization of breast and cervix tumors. Then she did the postdoc at the University of Aveiro and at the Medical Physics Department of the Oncology Institute in Coimbra, and where she worked in the implementation of IMRT for head and neck tumors and stereotactic IMRT for brain lesions. Some of our main interests are dose response modeling, evaluation of the efficacy of radiation therapy, and radiobiology optimization, and that leads us to this very first talk on biologically optimized radiation therapy. Brígida, the floor is yours, or the virtual floor at least.
So can you see my presentation?
Yeah, it's on, just needs full screen. Perfect.
The mouse. Okay. So today I'm going to talk about biologically optimized radiation therapy, and just to explain right away what is that I mean by that is the use of biological dose response models to optimize radiation therapy plans. And for example, here you see 2 dose response models, 2 dose response curves. And the green one shows the probability of tumor control, and the red one shows the probability of complications. So for example, if we radiate a tumor with an average dose of 60 grays, we will have a probability of tumor control of about 80%. Of course, at the same time, this means that the probability of complications will be about 10%. So what we want to do with biologically optimized radiation therapy is to have this information as input to optimize intensity modulated radiation therapy plans. So those of you that don't know what intensity modulated radiation therapy is, don't worry, because this is going to be the first thing that I'm going to explain in my presentation. Afterwards, I will give an explanation of why do we need objective functions and why biological objective functions have some advantages. I will give some additional application of dose response models, and then I will show a few dose response models for photons and proton beam therapy. And I will end my presentation with the limitations. So when we want to perform an IMRT plan, an intensity modulated plan, and this is a schematic representation of a head and neck tumor, where what we want to irradiate is the green structure, the target volume, and what we want to spare is the spinal cord. So as initial objectives, we need to define the prescription and the prescription dose to the tumor and the tolerance doses of the organs at risk, and you can use these as initial objectives. And after you perform inverse optimization to obtain a 2D fluence pattern. And for example, here you see a profile of an intensity modulated beam. So for a real clinical case, you see here a case where we want to irradiate the primary tumor and also the surrounding lymph nodes, and we want to spare as much as possible the parotid gland and the spinal cord. This case is going to be irradiated with 5 intensity modulated beams, and what we are optimizing is actually the intensity of each of these pixels. And when we do that, there are 2 main advantages. We produce those distributions with very steep dose gradients that allow us to spare this parotid gland, and it's possible to produce irregular dose distributions that will allow us to spare the spinal cord. So in inverse, to do that, in inverse treatment planning optimization, we need an objective function, and what this objective function is doing is actually judging in each iteration what if the new plan is a better plan. So for example, these crosses here show the different iterations of the value of the objective function. And for example, I'm showing here the simplest physical objective function, and where the prescribed and the tolerance dose are defined here. And these are compared against the planned dose. And when these two are the same, we have an L value of 0, meaning that you get exactly what you wanted. So to each objective that you define, do you have also associated an importance factor that gives you a weight of how important that objective is? So in the clinical routine, how is that this works? For example, we have here that we want to irradiate the target volume with a uniform dose of 76 gray. And then we also define the objectives for the organ at risk, in this case, the rectum. And you see, we are using here different dose volume objectives that are also defined here. And then you also have to define the importance factors or the weights. And here you are saying that the target volume is about 3 times more important than the rectum. So as advantages and disadvantages of these physical objective functions, most treatment planning systems nowadays are based on physical objective functions. And the objectives are familiar to us. All of us are very familiar with prescription doses, with tolerance doses for the organs at risk. The problem is that each of the objectives that we use in the optimization are associated to important factors, and these importance factors that actually don't have any clinical meaning. And as soon as the objectives are met, the optimization stops. Of course, afterwards, you can readjust your objectives or you can define new objectives, but this is a very time-consuming trial and error process. Although nowadays there are many or several automatic treatment tools that automatize this process and speed up the process. But still, you don't have any information about the expected treatment outcome, and the non-linear dose response curves of the tissues is not being considered. So in the 90s, Anders Bram already proposed that we should evolve from physical optimized radiation therapy into biological optimized radiation therapy, and this will result in an increase in treatment outcome, here quantified by the value of P+, and later we could also evolve into the direction of individualized biologically optimized radiation therapy. So in this case, we need a biological objective function. And in this case, what we want to do is that we want to find a plan that will produce the maximum probability of tumor control and the minimum probability of complications. And the P+ function in this simplest form can be given by the probability of tumor control of the probability of benefit minus the probability of injury or normal tissue complications. So during the optimization, what we want is actually to find the maximum value of P+. What we have to be very careful here is that in this value of P high, we can only include severe injuries. So that means complications that are as important as tumor control. So an example of how this works in a commercial treatment planning system, you have to first define the dose response parameters that, for example, here D50 and gamma. I will explain later what these are. So for each structure, this is a prostate tumor. And then we have the organs at risk, the rectum and the bladder. And once you define your dose response parameters and you calculate the plan, the treatment planning system displays the dose response curve for the probability of tumor control and the dose response curve for the probability of complications in the rectum and in the bladder. And the maximum value of P+ will correspond to the optimal plan, which gives here a value of 87.4, and the probability of complications for this treatment for the bladder will be 0.8%, and for the rectum will be about 11%. So just for you to have an idea, this is two dose distributions that were computed using biologically optimized radiation therapy. And we were comparing two plans using different number of beams. So this plan was computed with 4 intensity modulated beams and this with 12 intensity modulated beams. And what you see, with the increase of P+, you see that P+ has increased a little bit more than 2%. So there is an improvement in increasing the number of beams, but this increase is not considerable. Also in this study, we were trying to evaluate the benefit of non-coplanar beams. And what you see also by the P+ value, you see that clinically these two plans are not considerably different, so there is not really a good reason to justify a more complex treatment technique. So this is a study made by Kirkels and colleagues, and what they did was that they actually compared those distributions obtained by physical optimization based on UD. This UD already has some biological information incorporated, and using a biological objective function where they were trying to reduce the probability of xerostomia, dysphagia, and swallowing dysfunction. And as you can see, that if we compare the values of the probability of complications for xerostomia, dysphagia, and swallowing dysfunction, these clinical plans, they were based on completely physical objective functions. You see that all the time that when you do biological optimized radiation therapy, there is a reduction in the probability of complications. So what are the advantages of this biological optimized radiation therapy? First, do you use this P+ value that quantifies the quality of the dose distribution? So it's a very simple way of comparing the quality of the plans. If you use physical measures, it's really a complicated process because there are many variables that you need to compare. You also have a feedback on the expected treatment outcome, and this is information that you can provide to the patient and that he can very easily understand. Overall treatment time and dose per fraction are considered during the optimization, and you give much larger freedom to the optimization algorithm to try to find the optimal solution. And using this P+ objective function, you completely eliminate the importance factors that are very subjective. And of course, you obtain the optimal distribution in only one run, and you completely eliminate the trial and error process. Yes, there are limitations, and I will be talking about those shortly. Just wait for them. So recognizing the advantages of biological optimized radiation therapy, WAPM report published a report giving some recommendations on the use of biological objective functions. They speak a lot about UD, and they also give some recommendations on the use of NTCP and TCP models. So if besides using those response models for optimization, you can also use them for plan selection and evaluation. And this is a study that we did to try to quantify how much we will gain if we will move from conformal radiation therapy to intensity modulated radiation therapy. And you can see that the P+ value increased considerably. This mainly because there was a significant improvement in the probability of tumor control. And this is also because with IMRT, it was possible to prescribe a dose escalation of 5 grays, but the probability of complication also reduced from 80% to 33%. So the question is, how will these numbers change when we will apply proton beam therapy? This is another study that we've made where we wanted to apply those response models to try to find the local tissue response. So this is our generic dose distributions that we obtain in the treatment planning systems. And since we know what the radio sensitivity of each voxel, using this radio sensitivity and our dose response models, what you see here, it's a plot where you see the local tissue response of each voxel. So for example, what we want to irradiate is the black structures, and what we want to spare is the gray structures. In this case, this is the primary tumor, and it's very easy to see that here the probability of tumor control in this voxel is very, very small. So this is actually a cold spot that it's very difficult to see here, but here it becomes immediately evident. So for serial organs, this is also very straightforward to analyze because it's sufficient that you damage one voxel to cause injury. For parallel organs, it's a little bit more difficult because functionality depends on the whole organ. So just for you to have an idea on the shape of those response models, there are many, many models available. Here I'm only showing you the Poisson model, and the parameters that we need to find is the D50, and the D50 is the dose that corresponds to a 50% probability of response. And also, so you need to know the gamma value that quantifies the steepness of the dose response curve. And of course, we need to know these curves, their position and their steepness for each endpoint. And this means that we need to know them for each tumor, for each organ, for each complication, for each severity, and ideally for each patient. So there are many dose response models being developed for photon beam therapy, and most of them are based on dosimetric measures. Only recently, those response models started to incorporate clinical features. I just would like to highlight this study because it's a huge work that they've made where they derived 22 dose response models for different time points, and this allowed them to create a toxicity risk profile for every patient. So for example, here for xerostomia, which is a complication in the parotid glands, you see that during the weeks of the treatment, the probability of xerostomia starts to increase, and afterwards the probability of xerostomia starts to decrease. And here you see the list of the 22 endpoints that they derived and the corresponding probability of complications for each of them. An interesting conclusion that they took was that the integral dose was found to be predictive of fatigue, nausea, and vomiting. And when we talk about integral dose proton therapy, it's a proton beam therapy, of course, it's the best technique to spare the patient from integral dose. So the question now is, are the photon beam therapy models that we already have available, are they valid for proton beam therapy? Because with proton beams, it's a little bit more complicated because we know that proton beams are biologically more effective, and we quantify this by this RBE value. And this is a very difficult value to obtain because it depends on so many variables. So I will only be talking here about LAT. So this is the shape of the dose distribution for a proton beam. And of course, we like very much this Bragg peak and this steep dose with dose curve, because then it's very easy to spare all the organs that are behind the tumor. The problem is that there is this increase in LAT. And currently in the clinics, we are using an RBE value of 1.1. But if there is an organ at risk that is positioned right behind the target volume, we are calculating the dose distribution, assuming that we have an RBE value of 1.1, when it may be considerably higher than 1.1. So this needs to be considered. So in terms of those response models that were derived for proton beam therapy, we have there are many being available. I'm only going to show a few. So this is a case where they evaluated the mild side effects because the incidence of grade 3 side effects was very low. So they decided to focus on grade 1 and grade 2 side effects, and they used patients that with brain lesions. And in this case, they use an RBE of 1.1. And they derived those response models for different endpoints: alopecia, hearing impairment, fatigue, and memory impairment for different time points and the different severities, grade 2 and grade 1. And they even were, it was even possible to actually divide the cohort in patients that had less than 50 years and more than 50 years. And you see that the dose response curves are different for these subgroups. And they also found that this for alopecia and for hearing impairment, actually the dose response models for protons were quite consistent with those obtained with photon beam radiation therapy. And in this case, they obtain an AUC value quite good. So the AUC value, it's a measure that quantifies the predictive ability of the model. So a value of 1 will mean a perfect predictability. But here you see that the AUC value is a little bit smaller, and this means that there's still room for improvement. In this study, they used quite a large cohort, and this was for patients with choroidal melanoma, and they derived those response models for all these complications. And you can see that those response curves are considerably different. So you have to be very careful when you select the endpoint and the dose response model. In this study, they also study alopecia. So alopecia is loss of hair. And they also use a RBE value of 1.1, and they evaluated this complication at different time points. And you see that as the interval between the radiation therapy and the follow-up increases, there is an increase in the D50 value. And also that more severe complications like permanent alopecia has a much higher D50 value. And this model already achieved quite good predictive ability. So in this study of MDACC and colleagues, they actually wanted to quantify what will be the impact of considering the conventional 1.1 RBE value against two models that considered a variable RBE value. And what they did is that they collected follow-up images and they tried to identify on those images regions where they saw image changes. And here you can see that this is the red structure, and these image changes, they were considered surrogates for temporal lobe necrosis. And you see that when you consider a RBE variable, that the doses are much higher than when you use an RBE value of 1.1. So what are the consequences of this for dose response modeling? Is that actually here, if this represents the values of RBE of 1.1 and here the probabilities, when you consider an RBE variable, you see that the probability of temporal lobe necrosis was drastically underestimated when we use an RBE of 1.1, independently of the dosimetric or volumetric parameter that you are using. So in this case, the study of Moisenko, they were actually comparing different dose response models. And there are many models available on the literature, more simple and more complex, using less or more variables. But here it was trying to compare these four models. And you see that within the range of clinical where they actually deliver these plants, the models had quite similar responses. But as you go outside the doses that are delivered on the clinics, you start to see that there are significant changes in the risk, in the probability of complications that you will get by the different models. And this must be considered if you are thinking about performing a dose escalation. In this study, they were comparing also different dose response models. Here they compare the relative seriality model and the Lyman-Kutcher-Burman model. These are probably the most used models. And in this case, you see that their response is very, very different. Of course, they recognize that here the patients that are being used in the studies are different. So they grouped patients with breast cancer and patients with lung cancer, and the treatment techniques, they were also different. So when you use different treatment techniques, you are irradiating different tissues, so you may get different responses. So of course, there will be always uncertainties. And in this case, what I did is that I calculate the optimal dose distribution using my average patient, average in terms of radiosensitivity. And then I calculated the optimal dose distribution if my patient had different D50 values and different gamma values. And these are within the range of the standard deviations of the parameters of these models. And what you see here is the difference between the optimal dose distribution for this patient and this dose distribution, because this is the one that I can calculate because it's the average dose response values that I have. And you can see that if, for example, there is a new patient that comes to the clinics with this radiosensitivity, and I treat him with this dose distribution, actually I will have those differences of about 5 grays. However, the clinical response will not be significantly different. So you see that this value shows you the difference between what you will get if you will treat the patient with this dose distribution or with the optimal dose distribution if you knew its radiosensitivity. So this is a sensitivity analysis that I did. So of course we can do this in the research environment. Of course you cannot do this clinically. So we derived those response curves. We have our confidence intervals, and this gives you an idea of the range of radiosensitivity of the population. But what should we do when we actually have an individual patient that we need to treat? So for example, this is the dose response curves that I can derive because I need to group all the patient's response. But this is the dose response curve of one patient, of a second patient, and the third patient. And when you group all these patients, because you need to, you get a much shallower dose response curve. And this is why we have here a gamma value that is so small. So my last limitation on biological optimized radiation therapy, I called your attention that when you calculate the probability of complications, you should only include severe injuries. But how about non-severe injuries? Most patients develop non-severe injuries because we are very careful in the clinics not to cause non-severe injuries to the patient. So how do we include the impact of those in the optimization? So the complications, they are generally divided into grade 1 to grade 5, where grade 5 represents death from these complications. Grade 3 and 4, it's already severe complications that need clinical action. And then we have mild side effects that because of their persistence, they can significantly impact on quality of life. So it could be good if we also include this in the optimization. So there has not been much work trying to develop better biological objective functions, but actually in chemotherapy, there are a lot of researchers that are trying to develop a score that allow them to compare the efficacy of the different trials. I'm only going to speak here about the work of Lee and et al. And what they did is that collecting clinical data, they tried to derive weights for different complications and different severities. And using these weights, they can estimate the total burden score. The problem is that because of this methodology, this total burden score can only be applied to this trial. That this was the data, bortezomib in patients with lymphoma was the clinical data they used. So they evolved into a global toxicity burden score, where they actually try to derive score for all the organs that are listed in the CTK. And you can see that generally the scores that they found for grade 4 are higher than for grade 3, but there are a few exceptions. So it's very strange that a complication grade 4 has a smaller score than the complication grade 3. So maybe this guideline should be reviewed. So in conclusion, for each clinical case, the models are specific to the radiation therapy technique. So this means conformal radiation therapy or intensity modulated radiation therapy or proton beam therapy. You need to be very careful when you are evaluating absolute values of the probability of complications or tumor control, but the relative values that you calculate of probability of tumor control and complications, they are very useful for plan comparison and of course plan optimization. So what is that we still need? We still need those response models that accurately predict clinical outcomes. We need biological objective functions that reflect patient quality of life. And we need methods to predict individual radiosensitivity prior to the therapy. So thanks for your attention. And if you have any questions.
Thank you very much, Brígida, for your nice presentation. We have some minutes for questions. Alternatively, you can also send messages on the chat. I have one question like that. Is biological optimization already in clinical practice?
No. the clinical, the biological optimization using the P plus objective function is not being used because the clinicians are still very skeptical about the quality of the dose response models. The irony is that actually for proton beam therapy, they are used to select patients to identify those patients that will most benefit for proton therapy.
As a clinician, I must respond to that.
Yes, please.
So we're not, it's not about being skeptic. There are important uncertainties about biological dose distribution because the tumor changes throughout the treatment, the patient changes throughout the treatment, and what we plan in the beginning is not what is happening 10 days throughout the treatment, 20 days in the end. So we can't do a treatment plan where we don't know, where we know that a few days later, that's not what's happening. And in terms of proton therapy, this is a good idea. It's also not used for the same reason. And in the patient selection, we still compare protons to photons with a normal dose distribution. And I'll talk about that in my presentation without any biological considerations in clinical practice, not in the research investigation.
Yes, but actually, if the biological models are sufficiently sophisticated, you can include and incorporate in the models all these variations in the tumor.
Yes, but we're not.
So that can be considered.
Yes, yes, but we're not there yet. You are doing the research
yes,
about
but
that.
we need to improve the models to get there. Yes, exactly. I agree.
Yes, we're not there yet, so we can't add more uncertainties to the treatment plan. We need to do plans where we know what we're giving. We're sure of what we're giving. We're giving this dose to this location. We're sure what we're doing. We can't do a treatment plan based on what we think will happen. It's basically it.
Yeah, but actually the biological objective functions, they are just a tool to get a dose distribution that in the end might be very similar as a physical objective dose distribution. And it's a much faster way to obtain a much better dose distribution.
Yes, but being faster doesn't mean it's more accurate. It's not. We're not there yet.
No, because Cátia, you are confusing accurate of outcome that is expected, and what is not sufficiently accurate right now is the predictions of the models. So when I say that that dose distribution will produce 90% probability of tumor control, you don't know if it will be 90% or if it will be 95%. But the dose distribution is a dose distribution. So it really doesn't matter how you get it. But you opt with independently of the mathematics that is behind. If you get a good distribution, forget about how you got there. If it's a good distribution, it's a good distribution. What is inaccurate? It's the predictive ability that you have on the probability that you get from those distribution. That is the part that you are not sure yet. It's not the dose distribution that is inaccurate.
Maybe I changed the conversation a little bit.
Hello.
So Brigitte, I think UED models are used heavily in the US. I remember in Boston, we were using UED models in some of the biological predictions. And you're right, they are not truly biology. They're just a way of simplifying 3D dose volumes information.
Exactly.
And I think Radhe also has a lot of experience with a lot of these dose volume histograms, much more than I do. So Radhe, I'm bringing you into the conversation.
Well, I think this is a very interesting debate, but I have to say that, the famous statistician, I think George, somebody said that all models are wrong, some are useful. And this is the case. I think it is really critically important to continue to improve the accuracy of model predictions. Ultimately, even when we choose dose volume constraints, that is a kind of a model, based on our experience. So as we make them more accurate, we'll be able to make better predictions. I know Cátia is quite right that I think they're not good enough, but at the same time, I think we rely on dose volume histograms to make predictions, to judge whether the patient's treatment will succeed or not. So I think we are using more models in the clinic, but not necessarily more advanced models. And to use those advanced models, we need to continue to make them more accurate. And I'll say a few more words about that during my talk.
Yes.
I think it's really critical that we continue to make progress in that direction. I don't think people realize how important modeling is. The history of that's what I think gradually you look at the observations, regardless of the field, whether it's physics or chemistry or whatever, there are observations. Based on that, you develop a predictive model. And then based on that model, you make some additional predictions. And then you go back and see if additional observations become available. And then you refine the model. This is an ongoing process. So I'm hoping that the Brígida's models will be used in the clinic before I retire. Let me put it that way.
So just
Radhe,
to finish my
never
comment.
Retire, Radhe. I don't think you ever retire, which is a good sign because it's enough time.
Well, you have no idea how old I am.
You look very good.
I've been in the field for more than 50 years. So
thank you very much. I think we should move to the next presentation. Thank you, Brígida, for a very nice presentation.
Thank you for inviting me.
And also thank you to Anna, who asked such a innocent question and triggered our first small discussion in between talks. Our next speaker is Professor Mohan. He has extensive experience in the field of radiation oncology physics, including numerous pioneering contributions. Professor Mohan is co-principal investigator of a project grant entitled Improving the Clinical Effectiveness and Understanding of the Biophysical Basis of Proton Therapy, which is funded by the National Cancer Institute. In this UST Austin, Portugal program, he is the principal investigator on the US side of an exploratory project with INESC Coimbra on automatic treatment planning. Professor Mohan, the floor is yours. Thank you very much.
Thank you, Jose. Really appreciate your inviting me to give this lecture. I just want to start by saying that the use of proton therapy began many decades ago in the 50s and 60s. However, only in the last 20 years or so, the use has accelerated very rapidly. And now there are about nearly 100 proton centers around the world. But as we have been using these for a couple of decades in much larger number of patients, we are finding out that there's a lot more work that needs to be done. And in fact, Brígida pointed out some of those limitations that require a lot of attention and a lot more research. So for those of you who may not be very familiar with proton therapy, I'll give a brief overview. In theory, protons have a lot of potential. I'm trying to get rid of this thing on the top of my screen, and I'm not sure how to do that. Anyway, protons are very different from photons in terms of their physical properties, biological properties, and more recently, we discovered that they also have different immunomodulatory effects, and I'll talk about that a little bit later. And it's very important for us to understand these differences in order to apply proton therapy most effectively. However, there are many challenges. One of them is that the proton dose distributions have very high gradients, and they are perturbed much more easily by anatomy changes and setup uncertainties, much greater than with photons. And also, although we, as Brígida pointed out, that there are considerable gaps in our understanding of biological effectiveness of protons, and we currently continue to assume the RBE to be 1.1, which is not correct. So what all this means, and there are other sources of uncertainties also, and what all this means is that what you see on a proton dose distribution is not what we get, or not what the patient receives. And this is in part true also for photons, but it is correct to a greater extent with protons. And these are the factors that may be making it difficult for us to exploit the full potential. I think potential protons is much greater than what we have been able to exploit so far. That's just my opinion. And I think we need to do certain things in order to realize that. And also the fact that these uncertainties produce large error bars in dose distributions, or biologically affected dose distribution, that may be obscuring the true benefit of protons when you compare proton treatments with photon treatments. And as I was saying, the clinical results are kind of mixed. Some are good, some are not so good, and some kind of fuzzy. But as the time is going on, I think things are improving, but gradually. So in a way, because of these limitations that I pointed out, and there are many more than just a couple that I mentioned, there are lots of opportunities for further research and development in proton therapy. So proton therapy, I cannot see this at the top. I wonder if there's anything I can do to hide this on the top of my disable hide video panel. Here we go. Here we go. So proton therapy, in a way, derives its power to improve clinical outcomes from the physical properties of protons. One is that protons ionize more densely than photons. They lose their energy continuously. The rate at which the energy is transferred to the medium, so-called linear energy transfer, or LET, and the dose deposited increases continuously with depth, which is something like inversely as a function of energy. And the result of that is that the ionization density, and therefore the biological effect, which depends upon ionization density, also increases. And once they have lost all their energy, they stop rather abruptly, and that means they have a finite range. This allows us to produce sharp distal edges and sharp fall-offs, and produce more compact dose distributions that spare normal tissues, and now, as we're discovering, also the immune system. However, these sharp gradients or sharp fall-off also make proton therapy more vulnerable to changes in anatomy and other sources of uncertainties. There are two main ways of delivering proton therapy. One is passively scattered proton therapy, and that is rather rapidly giving way to intensity modulated proton therapy. But I'll describe it anyway, because up until now, and even now to some extent, passively scattered proton therapy is fairly commonly used. In both passively scattered proton therapy, PSPT, or IMPT, there are multiple beams that are incident on the target. For passive scattering proton therapy, a narrow beam of protons is incident. It enters the nozzle, the head of treatment head, and it is scattered and modulated and shaped electromechanically so that the distal edge becomes conformal to the shape of the tumor. In the form now that is taking over, the intensity modulated radiotherapy, again, there are multiple beams, but they are composed of pencil beams or beamlets that are magnetically scanned, and they're for a sequence of energies, and their intensities are varying so that a 3D pattern of dose is created. Intensities of these beamlets are optimized to achieve the most conformal, the best approximation of what our clinical objectives may be. Now, I think I kind of implied that the anticipated potential proton is yet to be realized, and I think I basically stated the reason: the greatest sensitivity of high gradients of proton dose distribution to motion, anatomy changes, setup variations, etc. Gaps in our knowledge of biological effectiveness. But another factor is that our treatment delivery and planning technologies and techniques are still immature, and they're evolving but they get in there. And I think that may be in part the reason why I think things are getting a little bit better. And another point that Brígida made was the limits to our extensibility of knowledge and models based on photon therapy experience to protons. In my view, in many cases, you cannot do that. And I think there needs to be either a better model for proton, a newer model for proton, or need to develop new models that can explain both proton and photon responses. And then there is heterogeneity in patient population, in tumor characteristics, sizes, locations, and genetic factors and treatment techniques that introduce large error bars, and that they may be obscuring the potential advantage of protons. And high cost of proton therapy is also limiting our ability to do research and clinical trials in order to find out, to learn more about protons. But I think this is nothing to be discouraged about. Things are changing for the better. Here's an old example, which is showing that this is the treatment plan here for lung, based on a single pre-breathing CT. And this is what we perceive to be the dose distribution, and we assume this is what the patient will get. But in reality, if you look at the moving target, you can see how dose distribution, the yellow line is the prescription dose distribution, how that is perturbed by motion of the tumor. And now I'm not showing dose distributions here, but you can just imagine that these are images of a head and neck patient over 47 days of fractionated radiotherapy, and the changes in anatomy have got to affect the dose distribution pattern. So in other words, dose distribution the tumor and the normal tissues receive, especially for protons, may be quite different from what we expect from the treatment plans. Now, intensity modulated radiotherapy, as you can imagine, is much more powerful than passive scattering proton therapy. But for a reason that I'll explain in a moment, it is also more vulnerable, more sensitive to inter-interfractional anatomy changes and uncertainty in range, biological effectiveness, and other factors. But this is an illustration from my colleague, Joe Chang, and what it's showing is that this is 3D conformal radiotherapy with photons, and you can see that the IMRT dose distribution is better than 3D conformal radiotherapy. And this is what we have been using until, I guess, 2000 something, early 2000s. And then when we introduced proton therapy, we found that you can spare a lot more regions here. But as you can see, that IMPT is even more powerful and can reduce the dose to surrounding tissue to a much greater degree. This is a simple illustration to make the point that IMPT is considerably superior, or can be considerably superior compared to PSPT. Now, here is a dose. This is an example that was lent to me by Tony Lomax. And what it's showing is that with IMPT, you can produce excellent, exquisite dose distribution, very conformal and very low dose outside. Now, this dose distribution is composed of 4 different fields, and each one has a highly heterogeneous dose distribution pattern that sort of fit like a jigsaw puzzle to produce this beautiful dose distribution. But in the face of uncertainties, that fit is lost. And what that means is that the dose distribution that you see here may be quite different from what actually gets delivered to the patient. So these are the kinds of problems that may be in part responsible for the fact that this is not all there is to it, but these are just examples to make a point that these uncertainties can cause proton dose distributions not to be as good as they appear to be on paper. And gaps in our knowledge, and Brígida went through some of that. The RBE has been and continues to be assumed to be 1.1 for every situation. In reality, it is a function of LET, dose per fraction, tissue and cell type, alpha beta ratio, and endpoint. And over the last decade or so, there has been gradual realization that RBE variability is important. But even now, I think vast majority of places, the value that is used is 1.1. Some changes are occurring at MD Anderson and Mayo Clinic and other places, but by and large, I think it is It is, we are beginning to use LET as a surrogate for variable RBE, but even that I think is rather limiting. I think we need to develop better models for RBE, and that effort is continuing. Now, this is a graph that Brígida showed. This is from my colleague Paraguan, and what it is showing is the RBE very slowly first up to the Bragg peak and then very rapidly. And this whole thing is ignored. I think the newer models that also Brígida talked about consider only slight increase in the linear portion. They ignore altogether what happens in distal edges. Also, RBE is a function of dose. And as you can see that lower doses, the RB is much higher than at higher doses. And another issue is the dependence of RB in some biological or genetic factors. In this example from MGH, what you see is for various lung cancer cell lines, depending upon the capacity of these cells to repair the DNA damage, there can be significant difference in RBE. For more resistant cell lines, the RBE is more like 1.7, but more sensitive cell lines can be as low as 0.9. In fact, what this means is that the photons are more effective than protons. So the consequences of these uncertainties and gaps in knowledge is biologically dose distributions are different from what is intended, and outcomes are mixed. And I'll give a few examples to make a point that although what we are seeing is getting better, but the fact is that so far it has not been a slam dunk that we had originally expected protons to be. The potential is there, but we are not there yet. And this, by the way, the red arrow points to the fact that this was a negative trial, a negative study. This was a randomized trial for non-small cell lung cancer, led by my colleague Xing Liao, and this was from 2009 to 2014. It was published in 2018, and our expectations were very high. In fact, when we started doing proton therapy, and we started considering doing a randomized trial, we were told that this would be unethical. We already know protons are better, and that to force patients or to make patients be treated with photons against protons will be very unethical. But then after a lot of thought, we decided to do this trial anyway. And what we found was this: there was no statistically significant difference in the primary endpoints, whether it's toxicity or grade 3 or higher pneumonitis or local failure. There was no difference between the two. So then what happened? And I think it's the points that I made. We are analyzing these data now, and we're sharing these data with our colleagues all over the world to analyze it further. And we're finding certain things, and so they're confirming the fact that it could be the interfractional changes in anatomy. It could be simplistic assumption about RBE, or the inappropriate extension of photon experience with proton, and immature technology. Some of the things that I just mentioned already, and the evolving techniques and learning curve. I think one of the things we found was that the toxicities in the latter half of the trial for protons were virtually zero compared to the first half of the trial. So that was an example of the learning curve nature of this trial. And heterogeneity. Some of the things that I'm re-emphasizing the same points, that these are the kinds of factors that could have affected the outcomes. And one example that similar to the one that Brígida showed, this is for the grade 2 pneumonitis. This was published in 2018 also. And what we see here is that mean lung dose and volume receiving 20 gray or higher is considered to be the sort of the constraints for designing photon treatment plants. And we use the same one for applying to proton plants. And what the results for grade 2 pneumonitis were that these are blue crosses are for photons, protons. No, sorry, blue are for photons and red ones are protons. However, on further analysis, we found that it was not the mean lung dose, but it was the root mean square dose that fitted the data, both protons and photons significantly better. And what that means is that in fact, the lung volumes receiving high dose matters more than we had been considering. Mean dose kind of buries the effect of high doses when you take the average of all the voxels. However, if high doses matter, then the root mean square emerges as the best predictor of lung toxicity. Another kind of negative trial was it was not a trial, it was a retrospective study of brain imaging changes of proton versus photons. And this was also carried out by a member of our division of radiation oncology. And that was for pediatric intracranial ependymoma patients. And this study was for MR imaging changes for 72 intracranial ependymoma patients, 36 with protons and 36 matched patients with IMRT. What is interesting here is that for IMRT, only 17% of patients had imaging changes in images on MR, whereas 43% of the patients had proton with proton. What is even more important is that 7 of these patients had higher grade image changes, which translates into hemorrhage or focal necrosis, compared to 0 for IMRT. So that's raised alarm bells among our practitioners, and they were wondering what's causing it. And the one thought was that maybe the higher biological effectiveness in the distal regions of the tumors. And in fact, my former student and our colleague, Chris Peeler, did the analysis and to try to answer the question, are the image change differences between protons and photons attributable to LET or variable RBE effect? So this is what he found. And in fact, what you see is that, by the way, both are same data plotted in different ways, that the image changes of voxel changes is a function of not just dose, but also a function of LET. And as you can see, this is as a function of LET plotted here for different doses. This is a function of dose for different LETs. And in a way implying the variable RBE is important. You cannot assume RBE to be fixed value of 1.1. A positive result was a retrospective study from Mayo Clinic that compared IMPT. Now, the previous data that I showed was for passively scattered proton therapy. This is for IMPT. And they found that IMPT reduces post-radiotherapy toxicities and hospitalization. And as you can see here, they analyzed 305 patients, 45 IMPT, and 250 VMAT intensity modulated radiotherapy modality. And what they found was that IMPT was associated with lower feeding tube placement. And this figure, what you see is that for X-rays, the feeding tube placement was increased from about 15% to 60%, but for protons, it increased from about 18% to 38%. So much better result with proton IMPT. And also the hospitalization within 60 days after radiotherapy was much lower for proton, this black region here, compared to black and sort of dark gray region here for VMAT. So both hospitalization and feeding tube placement were reduced with proton IMPT compared with VMAT. In addition, there was a 22% reduction for the end of treatment narcotics use, reduced cough and dysphagia, and patients felt less ill and had better swallowing. Another kind of positive results are from a randomized phase 2 trial. By the way, this trial has not gone into phase 3B within the national NRG organization. And this is randomized. These results are for the randomized phase 2B trial for locally advanced esophageal cancer. My colleague Stephen Lin is leading this, and the purpose of this trial was to compare total toxicity burden and progression-free survival for proton therapy versus MRT. Total toxicity burden is defined as the composite score of 11 distinct adverse events. So there were 145 patients, 72 MRT, 73 proton therapy. By the way, this is also passive scattering trial, and prescription are 50.4 gray. There was no difference in survival, but the total toxicity burden was reduced by a factor of 2.3 with proton therapy. And also it was reduced by 7.6 times in postoperative patients. So there is a substantial reduction in overall toxicity burden, but there was no difference in survival, which is kind of surprising to me, but maybe there is an explanation for that. There are many, many other studies in the literature. I will simply mention a few here. There was a negative study, by the way, red is negative, green is positive. So from Indiana University about radiation necrosis with proton therapy in pediatric patients. Pediatric patients with brain tumors treated with proton and radiotherapy. Proton radiotherapy demonstrated a high incidence of radiation necrosis and a short time to the development of necrosis. Whereas from MD Anderson, we found that superior intellectual outcomes after proton radiotherapy compared with photon radiotherapy for pediatric medulloblastoma. However, most of these studies are sort of like this. Radiotherapy associated with cognitive effect appears to be more attenuated than after proton therapy. In other words, it's suggestive of the good results, but further comprehensive studies are needed. In other words, most of the studies are small and they're finding some hints of improvement, but that again pointing out to what more needs to be done. In other words, although there is in principle much greater advantage that may exist with protons, so far the results seem to be only marginally better or getting better. I'll point to a paper by Prasanna et al. I think it's good read, very nicely done paper, and that reviews many more studies, and I think the references there will give the viewer or reader more information. Clinical outcomes, as I pointed out, there are opportunities for research, technology development, improving understanding of underlying mechanisms, and to achieve superior outcomes. Some of the research has already been going on, and as I keep on saying, that the results are getting better with time. I'll give one or two examples basically in the area of immune suppression and its mitigation with proton therapy. Just a few, one or two introductory comments that immune suppression with conventional therapy and its mitigation with proton therapy. Radiation-induced lymphopenia is very common across all types of tumor types treated with protons. But it's ignored and considered to be unavoidable, although photon radiotherapy is curative, but it has this side effect, which oftentimes patients recover from suppressed immune system, but not exactly. In other words, the changed immune system is still changed, although the total number of immune cells come back to about the same level, but the immune system's quality is still not the same as before radiotherapy. And also, high-grade immune suppression, high-grade lymphopenia is associated with poor disease outcomes. And what we found recently was the proton therapy, because of the compact dose distribution, it's exposing less immune cells to radiation, is less immunosuppressive than conventional proton therapy. So in this paper by our team, we analyzed the data for 504 proton and photon patients. And what we found was the radiation modality, proton or photon, they strongly influence mean body dose. In other words, protons produce a much more compact dose distribution than photons do. So mean body dose for protons is lower. Mean body dose lower seems to have translated into reduced grade 4 lymphopenia. And then grade 4 lymphopenia is related to outcomes. Here in this graph here on the left-hand side, what you see is data for combined cohort of protons. This is for all patients, protons as well as photons. And if the patients develop grade 4 lymphopenia, their survival was much poorer than the patients who did not, from grade 0 to 3. On the right-hand side, what you see is the results for protons compared with photons. The survival for proton patients was significantly superior compared to those for protons. And while this is not a definitive proof, but this is pointing out to the fact that if the lymphopenia is better with protons, or the lymphopenia is reduced with protons, then the survival is likely to be better also. Another paper that we just published was on GBM, and the basic point of that was the proton therapy reduces the likelihood of high-grade radiation-induced lymphopenia in GBM patients. We investigated the grade 3 lymphopenia. Grade 3 is still a severe lymphopenia. By the way, we were not able to establish the connection with survival here because the number of patients was less than 100. And what we found was, although the starting values were about the same for proton and photon patients, in fact, proton was about the same, a little bit higher than photons, slightly higher than protons. But after radiotherapy, the lymphocyte count was lower for photons than for protons. So that means more severe lymphopenia probability among photon patients than photon patients. And that grade 3 lymphopenia was significantly associated with baseline lymphocyte count, whole brain mean dose, and brain volumes receiving 5 to 40 gray. And very interestingly, we also found that difference between males and females. Females seem to be much more vulnerable to developing severe lymphopenia than males did. And we're still kind of trying to figure that out, why that is the case. There are some speculative reasons, but nothing clear yet enough. There are many other mortality. I think just my thinking is that immunomodulatory effect of proton therapy may make proton therapy much more valuable than it has been so far. So one of them is developing personalized models. And I think Brígida kind of also implied that. I think current models are population-based averages of those patterns, or volumetric dose distributions. And that's not enough. I think we have to take into account patient-specific characteristics and genetic factors in addition to dose distribution patterns. The response may depend upon tumor size, tumor location, neighboring tissues, comorbidities, and many other factors. So those things have to be taken into account, and perhaps we need to use some better statistical techniques, larger population of patients, to create some individualized or personalized model that can predict much more accurately the risk of a patient's developing either lymphopenia or other toxicities. And another is developing strategies for mitigation of the immune system. Once we have these models, we can predict a given patient's risk, and then we can also do optimization to avoid exposure of those tissues and volumes that lead to lymphopenia. And then another important point is that what we're finding is that the suppression of the immune system affects not only the outcomes of radiotherapy, but may also affect the outcomes of immunotherapy after proton therapy or radiotherapy with heavy ions. Yet another possibility is that the protons may induce more immune system stimulation compared to photons. Here's a quick example of where the survival of patient depended upon the condition of the immune system. For patients who had severe lymphopenia grade 3, for example, less lymphocyte count of less than 0.5, they did much more poorly in terms of survival than the patients who had a higher number of lymphocyte count in the bloodstream. So there are other examples of ongoing research and opportunities for future, addressing uncertainties related to anatomy variation. These are just reiterating what I said, filling gaps in our understanding of biological effects. personalized predictive modeling, and model-based selection. And Brígida went through that. I don't have the time to discuss it in detail, but this is becoming more and more important. But in order for this to be successful, the models need to be more accurate than they currently are. And proton flash, and João Seco will talk about it at length, I'm sure. So back to the original message, to summarize, proton therapy has considerable potential. I think a lot more potential than has been realized so far. Protons are very different than photons, and it is important to understand those differences. And however, there are many challenges related to anatomy changes and biological effects. And we need to understand better their immunomodulatory effects. And clinical results so far have been mixed, but they are getting better. And there are many opportunities to enhance the therapeutic ratio through ongoing research and future research. And with that, I'm perhaps a bit over time, but I'll end it here. Thank you.
Thank you, Professor Mohan, for your excellent presentation. We have now time for some questions from the audience. There is already one in the chat that I will read from Raquel Paiva. Could a model calculate a mean blood dose to predict lymphopenia?
Yes, indeed. In fact, there are a couple of, maybe more than a couple of papers. One of them is from MGH, and I think Clement Grasberger has some, he's a collaborator. He's collaborating with us on this program project that you mentioned. And we are going to be using that model to calculate dose to circulating blood. And also there are some papers by Jin, I think, and one of the other authors of that is Susanna Ellsworth. And but there are papers already, at least a couple of them I know of, and there is research going on how to calculate dose to circulating blood. I do have to say that the dose to blood is, I'm not sure if it's the only thing or it's the main thing. The number of lymphocytes in blood is only about 2% of the total number of lymphocytes in the body. So lymphocytes that are in nodes, in marrow, in spleen, and many other organs are also equally important, perhaps even more important. So we need to be, and nodes are all over the body. So it's not just circulating blood that may be important, but also, for all that is, in my mind, a bit controversial. But yes, indeed, there are models to estimate dose to circulating lymphocytes in blood.
We have a second question from Raquel Paiva. Could autotransfusions mitigate lymphopenia?
Could what? Oh, transfusion. Oh, yes, absolutely. Oh, sorry. I shouldn't say absolutely. The transfusion. So in fact, this is called, I think, leukapheresis, if I'm not mistaken. Is that so? In other words, blood is removed and the lymphocytes are removed and then grown in the laboratory and then reinfused in the patient after treatment. So that's one of the other strategies. There is yet another strategy that people are looking into, and that is the use of some drugs. I think it's IL-15 and IL-7, if I'm not mistaken. They can stimulate the production of lymphocytes. And so I think there are other mechanisms of doing it, but these are all under study. So strategies to, what I was talking about was the dosimetric strategies to prevent lymphopenia from occurring in the first place. And that's where the protons and heavy ions may come in. I think the dose distributions with helium and carbon may be even more compact and may further reduce lymphopenia. I think we need to study all these three mechanisms for this. I hope I answered that question that was close.
Thank you, Professor Mohan. Are there more questions? The next speaker is Professor João Seco. He is the department head of biomedical physics in radiation oncology at the German Cancer Research Center. João graduated with a PhD from the University of London the Institute of Cancer Research and Royal Marsden Hospital. He then went on to become an assistant professor of radiation oncology at Harvard Medical School in Boston, also working at the Massachusetts General Hospital. After that, he moved to Germany and he started work at the German Cancer Research Institute. Presently, he is also the chair of medical physics at Heidelberg University and is a member of the IFOMP Scientific Committee representing the German Society for Medical Physics. So, and to flash or not to flash is the title of his presentation. João,
thank you very much. Thank you very much, José. And I wanted to raise this question because it's really an open question. Even if we do want to flash, how do we flash? And sometimes we have to go slower with technology. When we don't understand it, sometimes we have to be more careful how we do it, how we translate it into the clinic. Okay, so let's see if I can move the presentation. Okay, so let's start with the key idea. I want this to be the first thing so that we have this right from the beginning. The driving concept of flash is that its ability to reduce normal tissue toxicity. So that's really the reason, okay? And it does that without affecting tumor control. So very small differences in tumor control, but they are at the moment shown not to be significant. So the key is flash reduces toxicity. This is the driver. All right, so I will mention a few things in my talk which are important. One of them is I will mention the so-called flash mechanism. So the possible models out there are several that have been developed over the last 50 years. This is more in the domain of radiation biology. It could be interesting for many people that do any form of radiation biology. Then I will mention something that is very common, that is the differential effect. So the difference between healthy tissue and the cancer tissue response to radiation. Right? This is where the majority of the studies, the animal studies, have really shown this differential effect. It doesn't mean that they've studied the mechanism, but they've clearly shown a differential effect. This is primarily important when we do clinical translation. When we go from animal models to patients, we really need to understand where's the benefit of the technique. Then there is also the clinical application itself. How do we use it in the clinic? How do we deliver? That was the question we were discussing a few minutes ago. This is primarily the domain of medical physics. It's our job to develop treatment plans which can or cannot include flash. I will not mention the dosimetry part. So this is primarily the physics part. And I will mention a European consortium called Ultra High Dose Pulse Empire. There's the link. If you want to read about it, then you can read about the dosimetry. I will not mention dosimetry. And what are the flash conditions? So I didn't mention the conditions for flash. I will mention them now. Flash conditions are high dose rates, 40 gray per second, and high dose, instantaneous dose at least 5 gray, right? These are just the borderline numbers. So you have to do both. You have to have a high dose rate and you have to have a high dose delivered instantaneously practically. So these two conditions are, you can call them the necessary conditions, 1 and 2. You have to have them both. One is not enough. Okay, so let's have a look at the history, right? In vitro and in vivo studies, which have done a mix of mechanism and differential studies, right? So the table in the screen is divided by years, by decades, sorry, in the 1960s and the 70s on the left, and the last 10 years, the 2010s and 2020s. And on the left is the type of study. So these are all in vitro assays. So usually 2D assays of cells. And you can see a very large amount of in vitro assays done in the 60s and 70s. And there's a lot more. I haven't put all of them there. There's like dozens of them. So there's a lot of assays. Started in 1967 for mammalian cells and went on to the mid and late 80s. So while in the last 10 years, there's been a handful of them. Like I only found 4 recent studies from 2019. And one of them is repeated by the same group. So the Adrian group did the study in 2020 and also in 2021 for different cell lines. Okay, so you see the major difference from left to right. There's a lot of in vitro studies in the 60s and 70s and a handful of them in the last 10 years. Now, the thing switches when you go to animal studies. So in vivo animal studies, there was very few of them done in the 60s and the 70s, but there has been a huge amount of animal studies in the last 10 years. I mean, a significant amount that I also could not fit them all in there. So you see the first paper that was the breakthrough paper in the last 10 years with the Photon paper in 2014. And then there was a flood of papers in the last 3 years and 3-4 years. And all of them have studied the differential effect of flash, where they show healthy tissue relative to cancer in a variety of animal models, from zebrafish to mice to mini pigs to cats, and you name it. So, and for a variety of models, cell models, okay? So this is a huge shift. And this indicates that in the 60s and 70s, it was physicists that were primarily working in the radiation biology labs. And now they tend to be biologists that usually focus on animal studies. And what were the models that were developed? So there was several models developed in different decades. The first model was 1967, and I will discuss these different types of models. And in this case, many of the models were also accompanied by experimental studies. And more recently, in fact, it's been a bit the opposite. You see a lot of the models without so-called experimental data. Someone has an idea, they write up, they develop a mathematical model out of it, and they publish it without too much of really close work with experimentalists. So the model based is primarily done by physicists. So the last 10 years, you see all these publications tend to come out primarily by physicists. Okay, so what models were there? All right, in the 1960s and 1970s, the so-called model that was developed that became really one of the most important is the so-called oxygen depletion. And it was proposed in 1967 in the Town paper and then studied further in a variety of papers. In the recent 10 years, it's become the gold standard for explaining flash, right? So oxygen depletion is basically dominating. Every paper up until recently had oxygen depletion as a possible explanation to what was going on in flash. If you look at all the other models, you see that the 60s, they have developed a variety of models, and few of them have really been kind of used to explain things. And more recently, there's also the development of models centered around this lipid peroxidation Fenton reactions. Okay? And the Ross and Ross studies that came out of Radhe Mohan's group. Okay, what about the in vitro studies? So let's start with one concept that is really important, the oxygen enhancement ratio. The oxygen enhancement ratio quantifies how oxygen sensitizes a cell to radiation damage. And if you have no oxygen at 0%, 0 millimeters, so 0 millimeters of mercury, if you have no oxygen, we usually define this as the reference point 1. And as you increase the oxygen concentration on the x-axis, you increase the cell kill effectively. And so you can go from 1 to 3 times more cells as you increase the oxygen concentration to your tumor. So oxygen has a very huge sensitization effect on cancer cells, increasing the cell kill by a factor of 3. This is a very important reason why, for example, the concept of oxygen depletion appeared. All right, so one of the first studies was the 1969 Berry paper, where they showed the effect of flash. And in here you have 2 survival curves, one in the white dots and one in the black dots. The white dots is your standard survival curve for cobalt at a standard dose rate of 100 rad per minute, which is 1 gray per minute. And you see your standard survival curve has this linear quadratic shape in a log scale. Now, if you flash that same amount of dose, you suddenly start to see a completely different curve. And these 2 curves meet at a specific point here, which is called the inflection point. Right? And that point is roughly 5 gray on these curves. Right? And what that means is, for some reason, if I flash the radiation in a nanosecond, I have a behavior that is not really the same as the one with standard radiation. And effectively, it's more resistant. The cells survive more to the radiation. So if the black line, the black dots are above the white dots, that means they are more resistant to radiation. And this is done on the left side for hamster cells and the right side for mammalian human cells, HeLa for human cells. And another study, more or less at the same time, explained the existence of this curve to be related to hypoxic behavior. So here again is the inflection point for a normal clonogenic with oxygen. And then suddenly you see the inflection point where you have the flash effect, and you see that the flash curve is parallel to a hypoxic curve, clearly indicating that the flash effect is connected to oxygen, right? And very likely, and this was the interpretation from the 60s and 70s, the cells are behaving as if there is no oxygen there. And this is what started kind of the concept of oxygen depletion. This paper, 1967 paper, basically launched this idea. Okay, so 1967 cell line and all the experiment, you see clearly this inflection point. You see this really nice set of data with a clear point here. If you look at the most recent data from the in vitro studies, you don't have such a clear inflection point. You do have a small difference that is significant between the two curves. And so here, the blue curve is the flash curve, the red curve is your standard conventional, and you see a possible convergence here for inflection point of around 2 to 4 gray. Right? And here, you don't see an inflection point. You just see that the curve is slightly above, the blue curve is slightly above the red curve, indicating, yes, there's increased survival, and it's statistically significant. So as you can see, these double stars and the single stars, but there is no clear inflection point. Right? So that was also, the quality of the data seems to be very different. So one explanation could also be the dose rates and the doses given. So in the 60s and 70s, he has a table coming out of a British Journal of Radiology paper by Wilson et al. And here they investigated all the papers published in the 60s and 70s. And one thing they observed is that they delivered a minimum dose between 5 and 12 gray, but the dose rates were extremely high. This is 10 million gray per second. It's basically a pulse every few nanoseconds. So it's extremely high dose rate compared to the flash studies, the recent flash studies. So it's possible that the quality of the in vitro studies are potentially related to these extremely high, ultra high dose rates. But this is very different from the recent studies where the flash rates are not that high. All right, now let's get to the in vivo studies, the more recent studies. So the famous Photons study from 2014, what they did is they compared 4.5 MeV electron given in flash mode with a standard X-ray beam given at normal dose rates. And the normal dose rate would be 1.8 gray per minute. And what they found is that if they flash the lung of the mice, so this is lung irradiation, with 40 gray per second at least. So here they're going at 60 gray per second. The blue curve represents 60 gray per second. That the level of lung fibrosis, the pulmonary fibrosis, so this is a toxicity effect, a side effect, that the toxicity is much more reduced in the case of the flash radiation. So 60 gray per second produces a fraction of lung fibrosis compared to 1.8 gray per minute. So the radiation given at ultra high dose rates, so in this case, just high dose rates, has protected the lung. And of course, the comment was that this is potentially related to oxygen depletion. So the radiation given at very high dose rates does not allow for oxygen damage. And they also did histology analysis. This is an H&E plot where they compare the non-irradiated with the conventional. And you see the huge amount of purple. This means the cells triggering cell death or dying. And you compare that to flash, and you see there's very few purple regions, indicating that the cells are really healthy and living. So this H&E plot really indicates the difference between conventional and flash. And this histology is extremely good sign that flash is protecting healthy organs from radiation damage. I would like to repeat, this dose rate of 60 gray per second is much, much slower than the 10 to 7 gray per second. All right. So the 10 million gray per second is ultra high dose rate. This is your normal dose rate for flash rates, 60 to 100 gray per second. This is 6 orders of magnitude different, but you still have this in vivo protection of the organs. They also looked at tumor control to see, does the flash also alter tumor control? And they found that it didn't. So in their studies, they had this head and neck carcinomas implanted in xenografts, and they saw that the dose rate for conventional, which is this blue line, was identical to the flash. And so they see these two curves follow each other. That means that tumor control is equal for conventional versus flash. So the effect is primarily in radiation in reducing side effects of healthy organs. Right? So the tumor control is statistically equal. And they found that if they go high enough, 25 gray per flash, they can even achieve tumor control, tumor growth arrest. So here you have completely growth arrest. The tumor has been stopped completely with flash. Okay, what about fractionation studies? So Montegruel also did recently studies of fractionations. What's the best fractionation for flash to compare? And they published it recently in 2021, I think it is. And he has the different fractionation regimes they looked at. They looked at 1 fraction 10 of 14 gray, then 2 fractions times 7 gray, 3 times 10, and 4 times 3.5. So these are 4 fractionation regimes that they investigated. I have represented the two last ones, the 4 times 3.5, and you see, sorry, that relative to this case, the tumor control is basically the same for the 4 times 3.5, and also a small difference between the flash and the conventional, but the tumor control is the same. And what you see is the growth of the tumor without radiation and the growth of the tumor with radiation. So they're practically the same. And this is a tumor injected in the brain of the mouse, in the right stratum of the female mouse. And you see almost equivalent tumor growth of the different fractures. But from a survival perspective, now this is significant. You see on the 3x10 gray, a significantly different survival. The mice that received 10 gray times 3 in flash survived longer. And this is statistically significant. And if you compare the 4x3.5, they have approximately the same survival, which is non-significant. So it's an indication that fractionation can also play a role in flash, and that would need to be in the order of 10 gray per shot to achieve that really true benefit. They also looked at something called novel object recognition, ODI, and they also showed that with flash, that the behavior of the mouse post-radiation was practically identical to the control. While if you gave the conventional method, that you had a significant drop in the ability to identify novel objects. So this was an excellent result from a clinical perspective. It says that fractionation also plays a role, and we have to investigate what's the best flash fractionation regime. Then we're looking now to clinical applications with electrons and protons. So there have been two centers that have used flash in clinical applications, and they've all centered around this initial animal study. So Marie-Catherine Vosnain and others have investigated animals with flash. They published a review paper where they showed all the animal studies for a variety of regimes, and that eventually led to the use of flash for a skin cancer. And in one of the papers published by Jean Boris in his study in radiotherapy and oncology in 2009, in the irradiation of a glioblastoma in the brain of the mouse, here they compared healthy brain for conventional and flash, and they compared the cancer for conventional and flash. So the healthy part of the brain is this blue line. So the blue line here is conventional, and this lower blue line is flash radiation. And you see that the increased toxicity is lower for flash. So the flash line is this blue line here. So I have less radiation toxicity of the healthy brain compared to this blue line here. So what you have on the vertical y-axis is the toxicity to the brain on the left. And you see that the blue curve, the dotted blue curve, increases toxicity very quickly for low doses if you do conventional radiotherapy compared to flash. And an immediate benefit is if you compare at the same dose of 10 gray, you see a huge differential between the two. So at conventional, healthy brain is received a high level of toxicity in the 80 to 90% toxicity level. But if I flash the healthy brain, I have significantly lower toxicity of 5%. And if I compare tumor control for both of them, the two orange curves, the orange and the brown, you have practically the same tumor control for the two curves. There's a slight offset between the two, but it's not significant, so you see a small bit. So the key key results of this paper, Jean-Maurice, they showed clearly a strong benefit of using flash in the case of healthy brain relative to conventional. So like I said, the first electron patient was then treated by Jean-Maurice's team in Lausanne with an electron beam, and they were treating a multi-resistant CD30 plus T-cell cutaneous lymphoma. And in this case, the person had received already a lot of interventions in the form of RT over the last 10 years, and he was struggling with this cancer. And so what they did is they delivered 15 gray in 19 milliseconds, so achieve a dose rate of 167 grays per second, extremely high dose rate, a very high dose of 15 gray, well above the 10 gray, so in clear conditions of flash. And what they found is very little side effects. So they grade 1 epithelius, so you see the reddening of the skin, okay? And even this is almost similar to a sunburn, a first-degree sunburn, and you see the thickening of it. And after 36 days, after 10 days and even beyond, you have total skin repair and recovery. So you have a really clear skin And all the side effects of skin toxicity, which were early stage, have gone. So this is a really good sign. They've been able to treat this and cure this lymphoma with this very high dose rate with minimal side effects. Okay, so the first proton patient was treated very recently in Cincinnati by Brennan et al. And they've used a flash to treat an extremity, like an arm or a leg. And they've given a single dose of 8 gray. So I think this is a little borderline for flash effects, but that's what the protocol has done. They've treated single dose 8 gray for a painful bone metastasis localized in one of the limbs. All right. And the proton therapy is conducting this trial, and they will recruit up to 10 patients as a feasibility study to study the flash radiotherapy on symptomatic bone metastasis. And the trial is called FAST-01. And the study is based on in vitro and in vivo studies in a previous study by Cunningham et al., where they did proton beam scanning irradiation of the mice, of the hind leg of a mouse. So they studied previously before going into patients, did in vitro and vivo studies, and checked that the doses would allow at least some form of flash protection. So it was based on this initial study. Okay, now let's move on to the part of the medical physics. How do we deliver flash? How do we plan? So I'm going to look into what the companies are saying, because they are also proposing things. So here is the studies that I got from research, and you see there are two main things that our companies are proposing. One of them is called shoot-through versus Bragg peak. So in the shoot-through, you put the beams going through the whole patient. So you're using the plateau region of your proton beam. And so you see one beam goes through, and in order to cover this volume, you need multiple beams to go through. So I'm not a big fan of shoot-through technology for flash, but it's one of the things that has been proposed. I think it will be hard to use multiple beams, but it's a possibility. The alternative would be to use a Bragg peak or two. So you shoot 1 or 2 Bragg peaks, and you need to deliver an instantaneous SOBP, right? And so you need something called a hedgehog, and I will mention that in a minute. In this case, you don't shoot through, you deposit the Bragg peak in or beyond the region of the cancer, like a normal plan, but you don't do IMPT, you deliver SOBP in one go. So how do you do an SOBP in one shot? You have to broaden your pencil beam, and this can be done with the case of a hedgehog. And in the case of the hedgehog, you will have the ability to modulate to both the distal part and the proximal part of your tumor. It is a little tricky to manufacture these hedgehogs, but you see more or less the shape of the hedgehog. The red one deals with the proximal part, the green one deals with the distal part, and like this you deliver approximately an SOBP. And you do have a little hot areas on the edges here, but it should work relatively well for flash. Okay, so research proposed that you could use flash with this hedgehog and compared it to an IMPT plan. Here, the IMPT plan has 32 layers of energy, while in the flash you have just one single delivery of the SOBP. Right? And you deliver this homogeneous dose that immediately covers your tumor, and you would do it with 1 or 2 beams between 8 to 10 gray per beam. That's what they propose. And I will show you, for example, if you do parallel opposed beams. Here you have 2 parallel opposed beams where you deliver a certain amount of dose and you achieve a homogeneous region in the center. And both of them are already delivering SOBPs, and you deliver a flat region which covers the tumor, and you have flash protection in the entrance channels of both of them. So in the plateau region, you have flash protection, and you have coverage of the tumor with these 2 beams. These are parallel opposed beams. You could also do what they suggested in the lung, where you could have 2, let's say, orthogonal beams, also delivering 10 gray each. So here you have beam 1 coming in from the anterior left and one anterior right, sorry, and you have another one coming from the anterior left. So you have these 2 beams. You deliver a distribution where each one delivers 10 gray, so it's 20 gray times 3, so 10 gray per beam, and you have a Bragg peak approach with your hedgehog and your end shifter. So this would be a nice way of also achieving flash with 2 beams. And here is the plan where they compare it to standard IMPT, and you see that the coverage is pretty good. It is a little hot here in the skin area of the chest and the chest wall and over here, but I'm sure that if you spend more time on this, you could potentially achieve a really acceptable plan. You want to achieve flash conditions in this entrance channels for here where you have the chest walls on both sides. but you also want to maintain coverage of your tumor, and you see the coverage is approximately equal, though the heart would be, we would have to check to see the heart dose also. All right, so I've discussed the flash mechanism, I've discussed the concept of oxygen depletion. So we did some work and over the last year and a half on this idea, and we went on to measure oxygen. And so in my lab, we did a lot of oxygen measurement with our oxygen sensors. And to discuss the oxygen depletion, I wanted just to give a quick overview of a little bit of a chemistry or radiochemistry so that you can understand some of the concepts I'm going to mention. So first of all, water radiolysis is the irradiation of water, effectively. And what you do is you irradiate water with alpha, beta, or gamma radiation, and you produce, in the case of protons, for example, ions, you produce the structure where you have all these spurs of radiation where the dose is being deposited. The water gets ionized or excited, and then it breaks up into all these additional components, which are the radicals, and they start to diffuse. So the water is ionized in these spurs, they start to diffuse, and of course, they start to interact with each other. So you have the so-called physical and chemical stage. The chemical stage is when they start to diffuse. And after a certain amount of time, the diffusion reaches the whole volume, and you reach what is called a steady state regime. And we define the so-called G value, or the amount of a certain radical present per a certain amount of energy. So the G value is defined at this point where you have the so-called steady state level around 1 microsecond, and you have the number of molecules divided by the amount of energy, 100 eV. And this G value can vary between a number of 0.5 and 3. Okay, and the reactions that affect oxygen are the ones that consume oxygen. So oxygen reacts with electrons and hydrogen, and the ones that produce oxygen. So oxygen can be produced by a variety of reactions, like the radicals reacting with superperoxyl and so on. So you can also have the case. So you always have a balance between consumption and removal of oxygen that is happening live with the radicals. So our study was published recently in Medical Physics, and we had submitted it late last year in December. And what we did is we went and measured the amount of oxygen that was present during flash radiation of 3 types, photons, protons, and carbon ions. We wanted to check, is there oxygen at the time or during flash? So what we needed to do is we needed to develop a specific sensor that worked in the phantom that was completely sealed. So no oxygen would go in and no oxygen would go out. And this sensor had to be non-invasive. So we didn't want to have a probe that was interacting with the cells. And it's suitable for all geometry. So we ended up building a small sensor, a small oximeter. And you see this whole sensor is completely sealed. And the sensor is inside the water. Right? In this case, it's filled with water. And the way it works is it's read out with an infrared detector. So you have to excite with a red light, and then you read out with an infrared detector the amount of oxygen. And the amount of oxygen basically tells you how much the sensor is working. So the more oxygen you have, the less near infrared emission you get. So it is proportional effectively to the amount of oxygen that's present in the medium. So we measured the oxygen depletion in different conditions. In the ion beams, we measured in the plateau region because that's where we want the flash protection. And in the X-rays, we measured it at different distances from the source, achieving a rate of 50 gray per second when we were very close to the source. So these are more or less the curves that you get. You have the oxygen concentration as a function of time. And you see that if you give enough dose to the water, you literally end up removing all the oxygen that is present. So at 52 gray per second, the oxygen removal is faster than at 1 gray per second. You see 1 gray per second takes 800 seconds. And at 52 gray per second, you're done in in about 10 or 15 seconds. And this is also true for different types of energies. And here we basically calculated the amount of dose needed to remove all that oxygen. You see that different levels of doses are needed to remove all the oxygen. So we also did the same study for carbon ions, of course, and now you see the nonlinear step structure, and this is in fact related to the spill structure of the ion. The ion beam, the carbon does not have a continuous beam. It has a spill structure with a few milliseconds spills. So that means you see the steps every time there is the buildup of the synchrotron with the charge, and then the removal is the time when the charge interacts with the oxygen and removes the oxygen. So you see a spill structure clearly here. And the same thing for the amount of dose that was needed to remove. In the case of the carbon, the dose was approximately the same. So then we wanted to quantify oxygen depletion as a function of dose rate. So here we have different dose rates from 0 gray per second all the way up to 50 gray per second, representing the photons. And what we noticed, it was in fact the opposite what everyone was thinking, was that the faster the dose rate, the less oxygen you remove. So at very high dose rates, at 50 gray per second, you're removing less oxygen than if you were here at 1 gray per minute, which is your standard dose rate. And this was a huge difference. So oxygen is less getting removed at high dose rates. So high dose rate is not consuming oxygen. In fact, it's consuming less oxygen. And this was true for photons, for protons, and for carbon ions. So it was consistent that all three had less oxygen removed at the high dose rates, which was a bit in contradiction to the oxygen depletion hypothesis. And we concluded that the main reason of that is that extremely high dose rates, that although at low dose rates you have the reaction of the solvate electron with oxygen, so you do produce the removal of oxygen here, at extremely high dose rates, the electron-electron interaction becomes dominant. And this leads to this possible plateau region here. So it's potentially true that solvate electrons at very high dose rates are self-annihilating each other before they can reach the oxygen. And that's why we observed that there was less oxygen removed at the ultra-high dose rates. And so then we decided to compare 50 gray per second, the amount of oxygen that was left. And we saw that it was much more when you compare that to 1 gray per second, the so-called standard clinic. So you see that all ions produce only a small fraction of oxygen is removed, from 2% to 1.7, 1.8. While here you have a much higher removal at your standard dose rate. So oxygen is not being depleted, and in fact, less oxygen is consumed at the high dose rate. So a bit in contradiction to the oxygen depletion. So you see that if I deliver 10 gray, which is what the models are saying, I have less oxygen removed. So the oxygen, first of all, is not depleted, but I also have less oxygen removed at the high dose rates when I compare to the low dose rates. So this was basically an indication that the oxygen depletion idea might not be the way to go for explaining flash. All right, so we come back to the question, right? So now this is an important question because I think we need to all think about it. It's not easy just to go and shoot at a patient and hope for the best. So are we ready to treat flash? No, I don't think we are ready treating flash. We are ready to treat because we don't understand the effect and the differential effects, the differential benefit that has been observed in animals still has to be studied in patients with more care. And even though there is a poor understanding of flash with radiation oncology, will the centers treat? Yes. You've seen already that 2 centers have started treating with electrons and protons. So of course, people want to understand how to use it, but at the same time, they want to use it to reduce toxicity. But we have to always keep in mind, we don't understand the mechanism yet. We don't understand how to take it fully advantage of it. So it is a bit of a black box. So I hope you've followed the flash talk. I focus primarily on the mechanism, on the differential benefits, and also on the clinical application so that you can get an overview. And I hope everyone is still with me. And thank you for your attention.
Thank you very much, João, for your presentation. Now the floor is open for questions from the audience or from the other members of the panel.
That means everyone has understood flash. That's a good sign.
Well, I understood, but that doesn't mean that I don't have questions.
Come on, Radhe, I'm waiting.
Well, I was wondering if the use of fractionation, I didn't catch it. Did that actually diminish the overall flash benefit? You showed some slides from Montegro.
So I think the fractionation helped show that you could use flash to maintain or even increase your radiation protection without affecting the tumor. So I'm sorry, maybe I didn't make that clear, but the benefit of fractionation helped even improve the benefit of flash because, you know, the fractionation helps normal tissue, and this was even more beneficial. And so they showed that that 3 × 10 was really a good way to go with flash, and that's what. But then,
when you fractionate, you're reducing both the dose and dose rate effectively, because your total dose has to be divided into multiple fractions.
Correct.
So if you do that, the flash effect actually depends upon a combination of dose and dose rate, as I understand it.
Correct.
If you
I
reduce
agree.
them both, maybe there is a threshold where you begin to lose that effect.
I'm not
And-
sure if there is a threshold, but keep in mind that every day they fractionated, they gave 10 gray. So they were achieving flash conditions.
Yes, they're giving 10 gray, but there may be some situation where you cannot give 10 gray for each of the fractions.
Yes, I agree.
And then the other question related to that is if you're shooting from one direction or when you shoot from multiple directions, the time gap between one beam and the second beam may also have
Yeah.
problems in terms of losing the benefit. I'm not sure if that's a factor or not.
So the study was single dose, single beam,
Yeah.
sorry, single beam.
No, I
So-
understand, but
you're
there
right,
may be
you have a very good
some
point.
argument that we should be shooting from multiple directions. Or alternative could be you can shoot, if you're going to give multiple fractions, you could shoot from one direction one day and another direction another day. And,
Absolutely. And that's what the research approach also suggests. Is sometimes the dose is so high that you have to divide the beams per day. You have to give one per day.
Let me ask you a question then. Is it possible that there is an interplay between dose rate and dose? Essentially, that means the instantaneous ionization density, that if you have to give lower dose, you could somehow make up for it by increasing the dose rate.
No, I don't. I think there is a threshold minimum dose. I know what you're trying to say, that there could be a phase space, but where you could increase the dose rate to infinite and maybe reduce.
Well, yeah. So you're saying that, the density of electrons, AEQ, what is that?
Solvate electrons, yes.
Solvated electrons. So if the density of those electrons is very high, by either through more dose or higher dose rate, could that make up for lower doses? That's why my question.
No, I don't think so. You need a minimum number of electrons, and there's no way to make it. So you need a minimum number of electrons to achieve your flash saturation, let's call it. And so you need a minimum number of electrons in an instant of time.
Mm-hmm.
So you cannot get around this so-called 5 to 8 gray number minimum.
Okay.
The problem is
what is I don't understand. What is the magical is it about 5 to 8 gray? Why not?
I know that's the biology part.
Yeah, but does it depend upon the biological sample?
Yes, I think it does.
Or oxygen levels and so on.
Also, it also depends on the oxygen level of the cells. So the two play a role for sure. So it depends on the biological properties and the oxygen levels of the biology.
Okay, but for each biological sample and each oxygenation level, there is a given minimum dose that has to be given before you can see it.
There's a minimum
regardless
number,
of dose rate.
That's what I believe. I think a lot of the experiments have shown that you have to be above 5 gray, and more recently there's been a difference in the philosophy between the Europeans and the Americans. In the clinical studies, they've always tried to give 10, 12, 14 gray in a lot of their studies, and in the patient studies, so 15 gray treatment. In the US, they seem to go for 8 gray. I'm not convinced I think it's borderline flash. We'll have to see if they didn't have skin toxicity. I'm still surprised. I have to see if they have skin toxicity from the Proton trial.
Oh, you're talking about the Cincinnati trial?
Yes, the Cincinnati trial. I think it's so borderline that I think they might even get cases where patients get skin toxicity because they're not in flash protection.
Okay.
We would have to see to be sure. They'll have to share the data with us.
Well, thanks. You gave a wonderful talk. I enjoyed it.
Thank you.
Other questions or messages in chat? Then I will ask one. João, what do you think are the next steps? Don't reveal any secrets, but what's on your mind of?
So Radhe has touched it. I think we need to learn a bit more about these techniques from flash to other methods that are out there. And we need to know how to use them. I'm a bit scared of these trials of irradiating without paying special attention to the conditions. But at the moment, medicine is an experimental science. We have to go out and do clinical trials and understand how best to do these things. But I think Flash still has a very far way to go. I think it would be wonderful to understand a bit more of it and then to use it. We have potentially switched on and switched off Flash in my lab. So at least we have a possible way of now investigating Flash. But like I said, we're still in the process of confirming these results.
If I may add to that, I think it seems to me that electrons are not going to be sufficient for Flash. And photons may also not be sufficient because the density of ionization is so low. Even perhaps with the synchrotron-based photons may be appropriate, but that's not going to be very practical. So it has to be particle-based Flash that I think may become clinical, if anything, for deep-seated tumors. And so I think protons and perhaps helium and carbon ion may be more appropriate for Flash radiotherapy. And that's where the study should go. But we can learn a lot from electron experiments, which can then be translated into what we need for protons and heavier ions, I think. What do you think?
I totally agree with you, Radhe. The big advantages now for ions could be Flash. It could create a differential that will be really beneficial for protons and carbon and other ions. And for electrons, it's really hard with the low energies to go deep, but there's also the research coming out of CERN on the very high energies for electrons. But it's still, you know, I think the big advantage now for Flash is ions, especially protons with the cyclotron. You can achieve extremely high dose rates. You just need to control. You just need to control the dose.
But the related question is then, you know, how important is pulsed structure versus continuous or quasi-continuous structure of these beams? Do you have any feel for that? Is it important to have pulse structure?
So I think we need to understand where this Flash mechanism is coming and understand its time response, because it's a biological process that has a time response. And if we know it, where it's coming from, and you know its time response, then of course our pulse structure will depend on that time response. So and I think that's the key. And I agree with you. We don't know the biological origin of Flash, so we don't know its time response.
That was my question. Are there any studies already that are looking at such things? Or
not from the biological perspective? I know there's a few studies now looking at pulse structure, trying to understand pulse structure effects. I know, especially Marie-Catherine Vosnin, they've done a few of these, and I think they're publishing now these different pulse structure studies. But I would be really interested to see if we can understand the origin of the effect and its time dependent, its time structure, because I think that's the key. And I think there was a review paper from Peter Wardman that came out 6-7 months ago that said, keep in mind always the famous oxygen study done 50 years ago, where they measured the oxygen response to be in the order of milliseconds. And I think that's what I think the pulse structure has to be, faster than those milliseconds.
Thanks.
Last chance for any question from the audience.
Well, thank you, and thank you for the invitation. It was a pleasure. Now I think it's time to go home. My kids are waiting. And it was a pleasure to meet all the others, Cátia, Radhe, and Brigitte, which is not here. Thank you very much.
Thank you, João.
Thank you, João.
Bye, thank you.
Thank you, everybody, the ones who spoke, who gave their presentations, and to the ones that put up with us for 3 hours, almost 3 hours. And well, especially to Professor Mohan, who's always our driving force.
I'll say that. I'm on the downhill, you know.
No. I'm sorry to. I disagree totally. I disagree totally.
Who are the future? Okay. It's so much fun to learn from these guys, though. I think.
Thank you very much, Professor Mohan, for all your support and all your enthusiasm and showing us the way. So with this, I think we can close the master classes of this year. Thank you very much again to the audience. And well, we hope to see you next year in another edition of our masterclasses within the UT Austin Portugal collaboration program.